So welcome to Spotlight on Stigma. We've got a great program today, as always. I'm joining today from the lands of the Bidjigal people of the Eora Nation, and I pay respect to the traditional custodians of these lands and to elders past and present. And of course, when we're talking about stigma and disease and burdens of disease and unequal burdens of stigma, we must also pay attention to Aboriginal and Torres Strait Islander experience of stigma and disease, and of course First Nations experiences across the world. So we have two fantastic speakers today. You will have seen in the invite for this, we've got a visitor joining us from 7 p.m. Michigan time, Rachel Khan-Best. A big welcome to you, Rachel. And we'll also have Elizabeth Deveny, who's the CEO of the Consumers Health Forum of Australia, as a respondent. And of course, as always, time for chat and discussion at the end. So Eleanor, I'm going to hand over to you.
So just to give a bit of background, so Rachel Best is Associate Professor and Director of Graduate Studies in the Department of Sociology at the University of Michigan. And Elizabeth Deveny is the CEO of Consumers Health Forum of Australia, which is the leading advocate on consumer health issues. So just a bit about the format of today. Rachel will speak first, and then Elizabeth will speak second. And if you can pop any questions in the chat, and we'll get to them at the end, and we'll have some time for people to also switch on audio and cameras to ask any questions. So Rachel, take it away.
All right. Well, Elena and Carla, thank you so much for the invitation. I'm excited to be here talking to this group. I want to also acknowledge my co-author, Alina Arseniev-Kohler, who's an assistant professor of sociology at Purdue University. And so our work started from a shared interest in trying to find ways to measure how stigmatized different diseases, disabilities, and health conditions are in ways that would let us make comparisons across lots of diseases and over time. And I want to sort of start out with just sort of like recognizing a trade-off in our kind of work, that by gaining that breadth and bird's eye view, we are losing a lot of the depth and understanding of the quality of the stigma affecting individual diseases. But we are starting from this idea that disease stigma varies. And in this paper, we are trying to find ways to measure that variation and to ask why some diseases are more stigmatized than others, and whether disease stigma has in fact declined over time. And in our paper, we sort of note that people have a lot of different theories about what might drive some diseases to be more stigmatized than others, and factors that might dampen how much stigma targets a disease, whether that's medicalization or advocacy by people affected by the condition, theories that the rise of patients' activism might have caused stigma declines over time. But what we kept running up against was that there's not very much comparable data. You know, if some of you are researchers, you probably have a sense of how hard it is to collect data and to measure how people feel, what type of, how they discriminate, what stereotypes they hold. And a lot of the time we collect that data using surveys or interviews of individual people. And it's a very time-consuming and expensive type of data collection. And it means that, you know, most studies can only compare a few diseases or conditions and only study the present, because people are sort of notoriously bad at remembering the past and being able to tell you about it. And so what we do in our work is turn to text as data, which lets us look across dozens of diseases over decades. And I want to note that when we measure stigmatizing meanings in text, we're not measuring the stereotypes that people hold or the discriminatory actions that people take. And so, you know, we're weakening our measures of those individual level variables. But you know, what I want to argue is that it's also important to measure these publicly circulating shared meanings. And so, you know, one thing that people with stigmatized conditions know is that you can be harmed by stigma even if you never interact face-to-face with another person holding discriminatory stereotypes. You know, the way you enter the world is shaped by the stigma you expect to face, the type of treatment you seek, the types of relationships you formed. It's all informed by these broadly circulating, culturally shared meanings. So we think that these meanings that bubble up in the news media are also important to measure. So to try to get these measures of the stigma targeting lots of conditions, we are looking at 106 diseases, including behavioral health conditions, infectious diseases, chronic conditions. We're looking from 1980 to 2018, and we analyzed 4.7 million articles from 27 US news sources. So this is newspapers with large circulations, transcripts of television news, news magazines, radio broadcasts. And so what do we do with all that text, these millions of news articles? We draw on a method called word embeddings, which is a relatively new text analysis method. It's gotten a lot easier for me to talk about this method now that a lot of people are familiar with ChatGPT and how that algorithm works by trying to predict the next word in a sentence or in a speech or text. Word embeddings are fairly similar. It's a computational text analysis method that maps the connotations of words by predicting missing words in experts. And so to try to, I'm going to try to give a not math heavy explanation of what word embeddings are by letting us pretend to be the algorithm for a minute. And so let's take a moment and try to imagine that you are a computer and you're trying to predict the missing word in these transcripts from news articles. And so you have a window of 5 or 10 words, depending on the researcher settings, before and after the word. So these are two excerpts from our corpus of texts. So turns describing what it is like when mom is a blank and the children bear the wounds of her addiction. First, so these are your cut off, you're just looking at the context this word appears in. The same words in another context. Controversial this year, it seems, which is substance abuse, alcoholism, or blank. There are people who are receiving a monthly payment to you. And so if you are the algorithm, you're sort of starting to get a sense of what kind of word might be in the middle. You sort of are getting, you might get a sense that it's a condition that people suffer from. It seems like it's something that harms people, just children. It's controversial to give people with this condition money. You sort of might be starting to pick up a lot of connotations from that window. Here's two excerpts with a different disease or condition. We'll offer a glimpse into a state-of-the-art experiment in blank treatment beyond radiation or chemotherapy. Is it possible that this other excerpt, farewell, an unspoken one, was because joy was dying of blank and might not live to see some of these good. So the algorithm is sort of trying to make a guess about what word is in the middle and then learning from its mistakes and updating as it cycles through the text again and again. And so it would be picking up that both of these are conditions that affect people, but it might be sort of picking up this sort of more positive moral valence around the second word, that this is something we're thinking about as a target for scientific research, something that people say a sad farewell. So the first word was substance use. We sort of combined various terms for substance use disorders into one we call a token. The second was breast cancer. And so the algorithm is sort of mapping the meanings of every word in the corpus. And we can start to see that words that are more similar appear in similar places. And so breast cancer and substance abuse would both be near each other on some dimensions in space as conditions that affect people, but far on other dimensions, for instance, an association with morality or immorality, negative personality traits or positive personality traits. So we use this embedding model to identify these two dimensions across which diseases can vary. And the first one we call judgment, which is based on the word's associations with either immorality or negative personality traits. And the second is disgust. And so you can think of these as every word in the vocabulary in all these news articles gets a score for whether it's closer to immorality or morality, negative personality traits or positive personality traits, and disgust or attraction. And we use these to measure how stigmatized diseases are. And so we can look across these decades how diseases are scoring and how it changes over time. And so we tried to pull together some predictions from the literature about how diseases would score on judgment and disgust. And so what we call norm enforcement theory led us to expect that we might see more judgment for behavioral health conditions, so addictions, eating disorders, other mental illnesses, where some theorists suggest that the source of the stigma is non-normative behaviors, that people are deemed to be immoral if they are acting in ways that are not normative, or that these conditions are sort of seen as casting aspersions on people's personalities. And that there also might be more judgment for conditions that are more preventable, that people are blamed for conditions that could be prevented by different health behaviors. And so I'm going to show you just what the contemporary data look like. So just from the most recent decade in our data. And so positive scores on the right are going to be connotations of immorality and negative personality traits. And negative scores on the left are going to be connotations of morality and good personality traits. And so we've got these behavioral health conditions clustered here on the right side with very high judgment scores, infectious diseases in the middle, and then chronic conditions, some variation. So, migraine headache does have a fair amount of stigma attached to it, connotations of negative personality traits, suspicions of malingering, so does Tourette syndrome. But most chronic conditions have much lower judgment scores. In our regression models, which I don't have time to show you today, we also show that diseases that are more preventable tend to have higher judgment scores, that we support this finding from the literature about individual diseases, that people do seem to face judgment when their conditions are believed to be preventable. All right, second, contagion avoidance theory. There's sort of some people approach this from an evolutionary theory based, sort of assuming that people evolved to avoid infection. Other people think of it as stigmatizers exercising power and trying to keep away people with infectious diseases. But both of these literatures led us to expect more connotations of disgust for infectious diseases. And so here's going to be a similar graph. Instead of the judgment index, we're looking at connotations of disgust for these different conditions. And as predicted, we do see infectious diseases having these higher connotations of disgust, a sort of surprisingly low score for HIV/AIDS here, which we think is because in the news media in the US, starting in the 90s, a lot of coverage of HIV/AIDS was about advocacy and philanthropy rather than coverage of individual people with AIDS. All right, so the literature also suggested two factors that might help decrease stigma, so that we might see less stigma for more medicalized conditions. So once we start to think of something as a medical issue rather than as, for example, a crime, that we might see less judgment or disgust. And then there's also some hope that when people affected by a condition come together and found nonprofits and lobby and advocate, that might cause stigma declines. So I don't want to spend too much time on this big table of numbers, but we found actually the opposite prediction, that diseases that are discussed in more medical contexts in our data tended to have higher scores for both judgment and for disgust. We think this is probably not a finding that will generalize to sort of big societal patterns. So for instance, as alcoholism across decades comes to be seen as a medical issue more than a moral failing, that still might well be associated with stigma declines. But I think actually in the news media, a disease making it out of medical contexts and being discussed in terms of human interest stories or coverage of philanthropy and advocacy, sort of making it out of medical contexts into philanthropic contexts might be associated with lower stigma. For advocacy, we see different patterns when we are sort of comparing one disease to another versus looking at the same disease at different times. So those are two ways that diseases can really differ in how much advocacy targets them. So there's some diseases across all the decades in our study that tend to have more nonprofits, more lobbying expenditures, more patients' advocacy. And making that comparison, we see a really strong link between more advocacy and less stigma. So the diseases like, breast cancer, for instance, has a lot of patients' advocacy and quite low stigma scores. The problem with those like between disease comparisons is it's really hard to tell what's causing what, right? So is it that this activism was very successful and has caused stigma declines, or is it that initially less stigmatized diseases means it's lower cost and more appealing to join a patient's organization? It's hard to tell which direction causality might run. So within diseases, we don't see any evidence that in a year when a lot of people found nonprofits or when they spend a lot of time lobbying the government, that stigma declines in the following time period. So we think this is sort of, it's certainly possible that these decades of patients' activism have had a result, but it's not like a strong signal with quick changes from year to year. All right, and then our last question was about stigma trajectories. And in our read of the literature, we found a lot of people suggesting that stigma might have declined over time, and that if it had declined, that these changes might possibly be mediated by medicalization and advocacy. And this is somewhere where, in the US case at least, there actually is fairly good data over time for mental illnesses, that people had sort of very carefully replicated the same survey questions across decades and shown a fair amount of stability for the stigma targeting mental illnesses. But it's been much less clear what's happening with all other conditions. And so I'm going to show you first our judgment scores over time for behavioral health conditions, infectious diseases, and chronic conditions. And so, higher is bad here. It means high stigma scores. And so we confirm this finding from the survey data that mental illnesses have remained incredibly linked to judgment over time, these connotations of immorality and negative personality traits. But what had not been observed before is that we really do see a big change for physical health conditions, especially chronic conditions, these big declines. And so what was surprising to me was actually how close these lines are together in the 1980s. That even diseases like cancers were sort of surrounded with these connotations of immorality and judgment and negative personality traits. And that's what has really melted away in the following decades. For disgust, the findings are not quite as dramatic, but we still do see declining stigma for chronic conditions. And then these sort of core stigmatizing meanings that were sort of strongest predictions from the literature about which diseases would be linked to which stigmatizing meanings have stayed very strong over time. So to sum up, we found support for some predictions from the literature for this idea that behavioral health conditions and preventable conditions would have the strongest connotations of judgment, and that infectious diseases would attract the strongest connotations of disgust. In news media texts, at least, we did not find any support for this idea that medicalization would be linked to stigma declines. And I put this in gray because it's sort of weak support for the idea that patients' activism has caused stigma declines. For stigma trajectories, rather than declines for all conditions, we saw declines for physical illnesses. And these declines were not explained at all by increasing activism for chronic conditions or increasing medicalization. There's something else going on. And we think that some of it has to do with increasing openness in discussions of physical health, and this sort of the stigma mechanisms that were leading to judgment for chronic conditions seem to not have been as strong and robust as those tight links between behavioral health conditions and judgment. All right, and so in thinking back to what our results suggest about the sources of stigma, we saw a convergence across the literature, whether these theories are hypothesizing evolutionary roots of stigma or roots based in the power and influence of people who have something to gain by stigmatizing others. Both of these theories suggest that some stigmas benefit the people doing the stigmatizing. And so that some people are benefiting when we are using judgment stigmas to enforce norms, or using disgust stigma to keep people with infectious diseases at arm's length. And these stigmas that seem to have these direct benefits to stigmatizers are the ones that are the strongest and most stable over time. So why were chronic diseases so stigmatized in the 1980s? At least in these measures we're able to pick up from their cultural connotations in news media. It doesn't seem to be doing anyone good necessarily. We think one possibility is these sort of spillover mechanisms. So, if one reason why people judge people with behavioral health conditions is this idea of punishing norm breaking and trying to enforce normative behaviors, chronic diseases also, the symptoms themselves are not norm-breaking behaviors, but they do prevent you from fulfilling your roles in society. And so there may be this sort of like secondary norm-breaking going on. And then, why are they disgusting? Well, they're not directly contagious, but there's some qualitative work suggesting like symbolic contagion, and that people may sort of perceive even non-contagious illnesses as potentially corrupting. But, we think that these kind of indirect spillover mechanisms, they seem to be, they don't necessarily stand up to questioning as easily. And so our data actually can't distinguish between two possible mechanisms. One that, as people became more open about discussing health, as people had more contact with other people with, cancer diagnoses, for instance, people sort of coming out with their diagnosis, if this might be a sort of health-specific decline, that these mechanisms of secondary norm breaking and symbolic contagion may not have stood the light of day, or possibly these sort of spillover stigmas, symbolic contagion, might have declined across conditions besides diseases. And we can't, all our data are about diseases, we can't distinguish between those two mechanisms. So the big change in our paper compared to other empirical research trying to measure how stigmatized diseases are is that we turned to text. And I think a big strength is that this lets us collect data across diseases and over time and sort of pick up these dramatic changes that weren't visible in previous studies, this decline in the stigma of chronic disease while mental illnesses stayed incredibly stigmatized. But as I said before, we're not directly measuring anyone's beliefs, actions, or discrimination. And so, even when stigma declines, when these sort of the stigmatizing connotations of a disease in the news media may be able to change while discrimination stays just as strong. And so I want to sort of have this caveat that we're not directly measuring the actions individual people take or the stereotypes that they may hold. But I do think our results suggest that cultural change is possible. So, Susan Sontag wrote that, she had this hope that we would regard cancer as if it were just a disease, not a curse, not a punishment, not an embarrassment. And I think in the US case, to a large extent, this does seem to have happened, that some of these connotations of immorality and shame and judgment and negative personality traits around cancer in the 1980s have melted away. And so stigma declines are possible. But I don't feel like I can end on a very optimistic note, given the incredibly strong and pervasive and continuing stigma targeting behavioral health conditions. And so while cultural meanings can change, they're especially resistant to change when they are serving the interests of powerful people. Thank you so much.
Thanks so much, Rachel. That was fascinating. I'll pass directly over to Elizabeth now, and just a reminder to leave any questions in the chat and we'll get to them in the Q&A.
Thanks very much, Carla. Delightful to be here today. So my name's Elizabeth. I'm the CEO of Consumers Health Forum. Consumers Health Forum is the national peak body for all Australians. You're a health consumer because you use healthcare services or you care for someone who does. And if you pay for tax, you're funding healthcare services. So it's important to you to know that that money is well spent. We started in the 80s when a lot of advocacy organisations started, and really as a consequence of the HIV/AIDS pandemic, where consumers and communities got very active, and you mentioned that also, Rachel, and started to demand access to clinical trials, changes in stigma and more compassionate care. And so shortly after that time, not only CHF, but indeed in Australia, and I imagine in the US, I know certainly in Europe, a lot of patient advocacy organisations bloomed and began over the next few years. So stigma has been important to us really from the very beginning. And your presentation, Rachel, which was, just wonderful, really vividly illustrated the harsh reality of stigma and the consequences that it might have in healthcare, despite the fact that you did note some variation across different situations. And does make you wonder why some conditions like substance use disorders might face harsher judgment than the chronic illnesses, and very illustrative, you're walking us through why that might be the case. And this disparity, as you pointed out, it's not just numbers, it's not just amazingly fascinating graphs. This is the consequence, this is the lived experience of real human beings. And for us as Consumer Health Forum, we're always advocating on behalf of individuals, and countless individuals in Australia are impacted by stigma that kind of is contagious in some healthcare environments. So one of the things to do, of course, is to start questioning our own biases. We've all got them. I've got them. You've got them. And how they might be impacting on the way that we provide healthcare, if you're providing healthcare, or the way that it might relate to other people, and use a compassionate lens rather than a moral one in the work that we do. The idea that you might be shunned, or you might feel that you'll be shunned or receive judgment as a consequence of reaching out for healthcare is, terrible, and particularly so when in some cases people might have more than one reason why they are already fearing that. Perhaps they've already experienced racism. Perhaps they've already experienced people who discriminate against them on the fact that they've transitioned. So they might have other reasons why they already experience stigma. And now there is also a health reason why they might experience stigma. So you could have a double or triple tragedy. And I think of something like, for example, Hep C, a contagious disease, which certainly people experience a lot of stigma about, which is now treatable. But if people feel that they'll be judged for even saying they have a disease, you have this double tragedy, not only of them experiencing that sense of social isolation, lack of inclusion, but also poorer health outcomes because they don't reach out for care because they think they'll be stigmatised. And in this case, they could actually end up with a much better health outcome. So the data, which was, I think I tried to count, over 100 different diseases, showed how the media shapes up perceptions. And we think of the mass media, things like the television, the radio, and so on. But increasingly important in our lives is social media, our Insta feed or our Facebook, if you're, over 70, or your TikTok, if you're my children. These things really will impact on behaviours. And for me, I always think about leadership and influence about nowadays. It's not something you do face to face, but it's something you also do virtually. So I think the challenge for us is we might, if we see an interaction, think we might intervene. The question is, when you see things online, do you have the skills in order to intervene? If you don't have them, you get them so that you can start to push back against the language that you might see in your social media chats or in some other environments. And I suppose kind of more broadly, Rachel's work makes you think about the fact that there is a promising decline in stigma for some conditions, but not others. And how can we help people who are experiencing those other things? It's interesting to see that as things get more medicalised, they become less stigmatising. So if you use the example of diabetes, someone who was having, too much or not enough sugar in their blood and as a consequence have behaviours that people mistook for being drunk or having used a substance. And now people are ready to say, oh, you've got something on your wrist. Do you have diabetes? And suddenly their response to the same behaviour changes because it's got a medical frame around it. What's important here, and I think you alluded to that, Rachel, is to use your terrific work, but also combine with that the lived experience stories of humans, both of their experience of stigma and the actions they may have experienced as well. And you did point out the language might change because people attempt to be what they might think of as politically correct, but actually the behaviours might not change. And so hearing from people and hearing about the behaviours that they're experiencing allows us to better understand the real impact of stigma on individuals. We know from our work, and the same is true in Australia, so things like breast cancer, dementia, some aspects of mental health, such as mental health in young people, have got a lot of money have gone into those spaces, prostate cancer, and as a consequence, there's been really strong advocacy. They have become more socially acceptable. Some cancers are more acceptable than others. Things like lung cancer still have a lot of stigma because there's this presumption that someone was morally kind of bankrupt because they smoked and that's why they got their lung cancer. None of this is, of course, correct, but it doesn't change the fact that some cancers seem to be more acceptable than others. We really do need to change that. And the work that organisations like mine and so many others all across the planet do to challenge these perceptions is incredibly important. And even more so as I think carefully about your work. Well, what do we need to do as individuals? I mentioned biases. We need to get ourselves educated. And if we are people who are in leadership positions, we need to make sure that everyone we work with has that education. So can we run some training around the impacts of racism? Can we look at doing some work on cross-cultural communication and safe communication with people, cultural safety and the like? So this is so important if you're in a leadership role to make sure that's happening within your organisation. For you as an individual, It's up to you to educate yourself. And so, coming to sessions like today might be helpful, but you also might find other things that you can do. There are so many resources available. I mean, you can now you can look up the amazing Carla and Rachel and find all their work and start reading that as a start. And I'm sure from there, there'll be more that you learn. And we know that communities can do that too more generally. So getting behind your community and supporting people who might be experiencing stigma and discrimination, equally important. And sometimes we see, and I've just mentioned in Australia, there's been a move, Rachel, around family violence and women being killed. There are many, many women being killed by their partners. And one of the big pieces of narrative you hear is women saying men need to be in this conversation. It shouldn't be women saying, please don't kill us. It should be men saying enough is enough. And this is the truth in these communities too. It shouldn't only be the communities who are often experiencing stigma and then ill health and then all of the other issues that might come with that are also expected to do all the advocacy and usually for free. So encourage everyone to think, is there a group that I can engage with in some way, whether I could follow them on social media, like their post, buy a raffle ticket, I don't mind, just do something to show you support, because the more people that do that, what Rachel's work says is over time that might make a really positive difference for people, which is so incredibly important. You mentioned my blog, and I was going to mention a couple of the stories in there. I recently did a blog talking about stigma in healthcare. I shared the story of my grandmother who had congenital syphilis, and through her whole life, that was a huge secret you were not to know. The consequence of that was quite significant on health, including her losing her hearing. She never ever reached out to the deaf community or hard of hearing community. She learned to lip read, and she was always very careful of not being seen, to not be able to hear in public. And as I got older, I reflected on this her being frightened of talking to people who had hearing loss, being largely because she didn't want to explain why she couldn't hear, which was because she had congenital syphilis. But that meant she lost the ability to connect with community. It would have been so important to her to talk to people who also lived in the silent world, because she was profoundly deaf. And I'm so sad for her that happened. In my blog, there's a story of someone who we'll call Maxine, who lives in a big city in Melbourne, and whose daughter had a disease that caused some symptoms, including issues around her fitness and about her body shape, and talked about her going to school and the PE teacher, the sports teacher, forcing her to run and run because, and saying in front of the rest of the class, well, you're fat, you need to get out and move more, making her so ill that she had to actually be withdrawn from school for 6 months so that she could be healthy, because the school were making all kinds of assumptions about her lack of fitness and other things, because they didn't think she looked like she had anything wrong with her. Love that one too. So this stigma occurring everywhere, and the impacts again for this young person who's having this called out in front of all their classmates, who's unable to participate in things that she wanted to do, and her family needing to take protective action, which is take her out of school. We're pleased to know she's now older and thriving, so that's fantastic. But to have this experience, it's really not acceptable. And I think my last couple of comments about the things that came up for me as I listened, and also I had the luxury of seeing the slides before today, so I got that extra benefit. That's great. Thank you so much, Rachel. Was the need for capacity building for consumers to tell these stories safely. It can be triggering for people to tell these stories of stigma and abuse. So how do you make sure that everyone has the capacity to safely tell their story, and that qualitative work comes and, like a tapestry, builds the story of stigma. I hate but love your notion of symbolic contagion, and think about, well, how can we do something about that? Whether it's your race, your ability, your postcode, that somehow means that, we don't want to be like people like that. I couldn't help but think of Foucault, because I'm a huge Foucault fan, and the panopticon. So this notion that you'll be in jail and the jail is in the middle, and can able to see, and Deb, if you're online, I know you'll love this reference, see what you're doing. As a consequence, you self-surveil and you don't do certain things because, someone might see. And so if you feel something about it, you might be stigmatizing. And straight away went to people who are neurodiverse and who mask. If you think something might be stigmatizing, how that changes your daily behaviours, and how difficult it can be having people close to me that do that and tell me how exhausting it is at the end of the day, having to behave differently so that they won't be judged. I did think also about the fact that you've used this big data and the dangers of AI. I'm always thinking about AI. Can't have a conversation nowadays without AI. And the kind of magnification of biases due to the compounding impacts of AI, and the way that those large language modules are just taking everything off the internet and using that to decide, what the community thinks. So if that stuff is full of stigma and bias, and we've seen this in some evidence around AI, but this is just another example, and they learn on that, and then they provide responses on that, and then people read that and think that's normal, so then they behave in that way, and then they write that way. So it's almost like, well, how do we reverse that? The more that you can virtually, on your, as I said, electronically say, this is not okay, provide safe narratives, provide these stories, talk about the things that need to be done, the better we can start to actually, over time, maybe even reduce the, troll ratio on the internet and improve the quality of the language that's occurred. So it's a terrific presentation from a consumer perspective and advocate perspective. There's so much in there I could talk all day. I'm sure that's more than enough of my kind of initial response, because many people will have questions they'd like to ask you. Thank you.
Thanks so much, Rachel and Elizabeth. What a juicy, rich tapestry we had this morning to get into. And I'll put a couple of links in the chat for people to go and check out the Consumers Health Forum of Australia. And if you hadn't come across CHF before, terrific to have such strong advocacy, being able to really put forward some expert knowledge and advocacy on stigma in healthcare. So thank you, Elizabeth and the team, for all that work. So Eleanor and I are going to manage the conversation from here, and there's a lot going on in the chat, really long, juicy, again, perspectives. Jack, did you want to jump in and ask your question about cultural differences and cultural groups?
Morning. And that was fantastic. This has been really interesting, a very interesting perspective. And Rachel, you terrified me when you showed me that graph and all of those numbers, and the kind of, it was just, but you explained it beautifully. I work in hepatitis B, and I don't know if your methods have the nuance to be able to do this, but to identify within hepatitis B, there's different responses within different communities. Between different ethnic and cultural communities, and some particularly around stigma. So for Chinese people, kind of stigmatized, deeply embedded, it's around, and it affects kind of social life kind of really strongly. Within other communities, it's like, no, not an issue. Is there any way that the methods you use can I don't know. Yeah, can bring that forward. Sorry, that was deep.
It's a fantastic question. Yeah, so our methods are sort of taking the big corpus of text that we feed them and picking up the cultural connotations within them. And so the big batch of text that we gave the algorithm was news texts from United States mainstream media. And so, I think this method could be applied to, Chinese mainstream media, for instance. And so to sort of think about, you could do a country comparison to think about, do those connotations change across countries? I think, for subgroups within a country, you need enough words to be able to pick it up. And so, I'm very interested in applying these methods to social media, to people's online posts. I think for smaller communities, it would be difficult to get enough text, but I think there is a potential that, you can compare across any texts. But of course, it still would be measuring these broadly circulating stereotypes and connotations, and not necessarily the variation in what people believe or in their discriminatory actions.
And thank you for clarifying that it was US. And I was also gobsmacked about the kind of the difference between HIV and hepatitis in terms of the findings. That blew my mind. Thanks, Carla.
No worries. Elizabeth, did you want to comment at all about the work the forum does, being able to represent or reflect the experience of people from a range of different communities and backgrounds on this topic of stigma?
Yeah, so thanks, Carla. We do raise issues of discrimination, bias, stigma, all of those things in our advocacy work. While we advocate for all Australians, we're particularly focused on those Australians who experience most health disadvantage. And often there's an intersectionality there, that same compounding thing where people who might be stigmatized for various reasons might also have health situations that might impact. And, Anthony talked about the impact on work in the chat. So you might find it difficult to get work because of something to do with your health condition or something to do with the stigma related to your health condition. Talking to someone recently who had been diagnosed with epilepsy and said that, the employer was thinking maybe that she didn't have their job anymore, even though they could do it well until they found out that they had epilepsy, right? So all of this is so important. And people sometimes, are reflected on the areas of stigma and discrimination that I'm most passionate ones about are the ones I've had personal experience of. So working in the drug and alcohol community and working in mental health, working with young people, working with older people. So that because I've got lived experience, either a family member or people who've advocated with it, I get, super passionate, more excitable than normal about these things. So I think for CHF, it's very important that people are connected to us and tell us this story, so we can be making sure we include all of that in our advocacy. I feel like that there are some groups that we actually have a better handle on than others. So for yesterday, actually talking to the Centre for Healthcare and Intellectual Disability and thinking about how do we include the impact of intellectual disability, which of course a lot of stigma with that one too, and what are the effects there. So I love people to reach out and join us either as members or simply like us on LinkedIn or the like, because the more of those stories we get, the better job we can do of really kind of teasing out when I'm sitting with health ministers and senior people of all kinds, the complexity of this and the different ways that stigma might be experienced through language or actions.
That's a great invitation to give the forum the ammunition to take into those high-level meetings, Elizabeth. Thank you for being so open about that. Penelope, you've raised the baby boomer hypothesis. Do you want to jump in with that one? That's an interesting perspective.
I'm just having trouble making myself available.
We can hear you nice and clearly.
Yeah. So, yeah, it just occurred to me that when we're talking about chronic conditions and saying why are some of them becoming less stigmatized, it seems to me that baby boomers often are in positions of power politically and in the media. And as they start to acquire those conditions, are they then driving a change in the way those conditions are discussed? And shifting the stigma, because they as a powerful group are in a position to do that. And what I was about to write, it's very interesting for me. So I have myalgic encephalomyelitis, ME/CFS, and epidemiologically what we know is that it's a condition that is more common in disadvantaged communities. In the United States, epidemiologically, Indigenous Americans have the highest rate of ME/CFS, the lowest rate of diagnosis, because when you have a stigmatized condition, you can't even convince a doctor that you have it. So the intersectionality and the way that interacts with stigma it's powerful beyond anything that you can pick up in the media. You only get that when people do huge studies and they go around and they go diagnosing people and say, well, we've discovered all these people with this who are undiagnosed, and we've identified that the rate of lack of diagnosis is pretty proportional to the extent to which that community is stigmatized and disempowered and vulnerable. So that's what makes me think, well, maybe, if the average, especially affluent, educated baby boomers acquire a condition, they can actually drive change in stigma in a way that disempowered communities are just not in a position to do.
Those are fantastic points. And I think you're right that the baby boomers are the generation that sort of experienced and drove this change in the declining stigma of chronic conditions. And, I think when you first phrased this question, I thought you were arguing that, having a generation, having the people in power who are at the age to get chronic conditions is what destigmatizes. And I think that was probably also true, in the 1940s and 1950s and 1960s, that the previous generations were then in power and at ages of at risk of chronic diseases. And so I think it's less about that generation aging into chronic conditions, but I think there is a sort of generational experience, whether it's the consumers movement or the women's health movement or this sort of increasing openness and discussion about physical bodies. I think the sort of declining deference to physicians and taking control over one's own health, I think this is the generation that sort of stopped saying, I don't want you to tell me if I have cancer. That's sort of wanted the information. And so I think there is absolutely a generational effect, but I think it's less about aging into power and more about the sort of social movements and changing status and interactions with the healthcare system. Your second point is such a fantastic one about these conditions where you have to fight to get a diagnosis, and when there's so much doubt and skepticism from healthcare providers, from families, from employers. Some of my other research is about the outcomes of employment discrimination lawsuits around disability in the United States, and the sort of biggest disadvantages we see are plaintiffs with pain conditions that don't have what are perceived to be objective diagnostic markers. And so, people seem to have face such doubt and judgment from their employers, from the judges. And the finding that was really stunning to me is even when a judge is willing to say, this is a person with a disability, they're still less likely to win their lawsuit in other ways. There seems to be this sort of spillover, these sort of stereotypes of malingering, and this suspicion seems to just sort of poison how people are viewed in a way that's, as you say, so clearly, especially harmful if you're facing other forms of disadvantage.
Thank you.
Thanks for that. I might jump, there's a bit of a great conversation going on in the chat about intersectionality. And so the question is whether, and I think this question can be both for Rachel and Elizabeth, whether you've got any comments on whether the burden of stigma is gendered and whether conditions experienced by minorities are more likely to be stigmatized. So maybe we'll start with Rachel and then we'll go over to Elizabeth.
I love this question because this is what my co-author Aline and I have been working on for the past year. And I guess the first thing I'm going to say, which is sort of one reason we've struggled with this next paper, is this complication that there's two ways of thinking about how a disease is gendered or racialized. There's data on who actually is diagnosed or who actually dies and what their gender and racial identifications are. And then there's the sort of cultural connotation of the disease. And so these things are quite associated. In our data, we can actually measure both. We have data on who the patients are, and then actually also data from these word embedding models on which diseases are associated with femininity or with Blackness, for example. And one complication is they don't always go in the same direction. And so we don't see like a strong and systematic pattern where women's or men's diseases are more stigmatized, but we do see these sort of like different avenues for stigma, different stereotypes that get associated and linked up. And so, when we look at the sort of, these methods are sort of mapping words in space, and the sort of words that appear close are ones that share similar connotations. And so stigmatized women's conditions attract negative connotations around sexuality, around promiscuity and physical display, whereas stigmatized men's conditions like alcoholism attract stigmatizing sexualized connotations around promiscuity and philandering. And so both men's and women's diseases are sort of able to attract these types of judgment, but there's not a systematic pattern where men's or women's diseases are more stigmatized. Our hypothesis going in was that diseases that affect more women would attract more sort of doubt and suspicions of malingering and judgment. And we think there's very strong evidence in the literature that that happens to individual people who are seeking healthcare, that women are less likely to be believed and also more likely to experience these sort of subjectively diagnosed conditions. We did not see a sort of systematic gender pattern across lots of diseases. The race patterns were stronger, that diseases and conditions that affect more Black people in the US and that are sort of culturally associated with Blackness tend to have stronger connotations of judgment and of criminality.
I was thinking that this also this question of gender particularly connects with the conversation you were just having before about convincing doctors of your pain, for instance, because we know from the research that doctors often don't believe women when they do express their pain. Elizabeth, could you comment a little bit around, what CHF has heard around gender and other minorities and experiencing stigma?
So if I kind of try to make a relationship between stigma and access to care, we know that some conditions it's much more difficult to get access to any care, let alone great care. We know that the funding for conditions varies. And so, people who experience cancer sometimes talk about being lucky enough to get the kind of cancer that is well funded versus being unlucky enough to not do that. And we look at the impact that people like. There was a well-known media personality, Ita Buttrose, some Australians will know, that led a whole lot of the conversation around dementia and made that much more palatable. We had a famous cricketer whose wife sadly died through breast cancer, that created a whole lot of support for breast cancer because people like cricket, and therefore breast cancer's okay. So absolutely that then impacts on the quality and ability for you to get services. So what we see is that the same things that cause discrimination in other parts of your lives are likely to impact on the kinds of services governments fund and the kinds of services that are available, let alone whether you feel safe to do those. And I was at a workshop last year run by government, and I won't give you much more detail on that, but we were asked as part of the activity to get a piece of paper and draw a picture of a person that would be a heavy user of hospital services. I just want that to kind of just think about that. We were asked to draw a picture of a person who actually was a heavy user of hospital services. So they thought that visually we could depict this, which speaks to, well, what kinds of personal attributes did they expect we would express on our piece of paper? Well, that's enough.
Not questioning what are the systems failures that might have led to people being a high user of hospital services.
No, we didn't.
All very individualized, huh?
Yeah. So I sometimes think that even, and you and I talked about this, when we talk about the social determinants of health, that can even be a bit victim blaming. Well, it's your fault because you're black or because you're poor or because you're whatever. If you weren't those things, you wouldn't be having such a bad experience. But I'm sorry that you're having it. But part of this is just because of who you are, right? I just think that we need to call that out, and that means us having the skills to be able to do that, whether it is face-to-face or whether we see content. Maybe that means that we stop following people, maybe we make a comment about it, maybe report or block them. There are things you can do rather than just scroll on past when you're in that kind of death scrolling and can't get yourself motivated to actually take action.
Okay, I'm just looking at the comments. I see one from Emma about HIV and criminalisation. Do you want to jump in, Emma?
Thank you, Carla. Yeah, look, it's just for me, it's this age-old, really deep stigma and discrimination that is built on so many layers going back to the 80s, 70s and 80s of homophobia as well. And I do think that attitudes change from the top. So if you change, and what's more powerful than a judge in the criminal justice system making a judgment about somebody living with, a chronic condition and then deciding that they're using that chronic condition as a weapon. No other disease or condition is weaponized or criminalized under the legal system. It has to change. And I talk about keeping up with the research, U equals U, not just HIV, but other things as well with respect to anti-vilification laws. It's just not keeping up. And sorry, I'm not looking at the camera either. And if it doesn't keep up, then people's opinions in the community can't change. They are still living with the belief that it's a bad thing. And it will continue to be stigmatized and discriminated against. And it has to change. Apologies for the border collie in the background.
Oh, I love the border collie. That link between keeping up with the science and then that being reflected in the media, which is then reflected in Rachel's analysis, right? To be able to and might show decline in time in declining stigma over time as people understand what U equals U means for people living with HIV and for the whole of society. We've just got 4 minutes left, so I wondered if Rachel or Elizabeth, there were any final thoughts you wanted to bring back to the group, having seen some of the great stuff in the chat. And sorry we didn't get a chance to get to everybody's point, but Rachel and then Elizabeth, what might you want to leave us with?
Well, I guess one thing I would say is that there have been a lot of fantastic questions about, what do we do next? And one thing that I would hope is that this sort of finding about some conditions that maintain these very strong cultural connotations, I think that could feel very demoralizing in some ways. But I think, thinking about psychological research, this sort of existence, this sort of swimming in a sea of stereotypes, these sort of unquestioned assumptions about links to immorality or to negative personality traits, that you can be exposed to stereotypes and then there's still a lot of variation in the extent to which they affect your behavior. And so I think that the work that a lot of you are doing of sort of making people aware of these faulty assumptions can allow people to just pause before acting unthinkingly and letting stereotypes shape their actions. And so I think it's probably a losing battle to try to purge our shared culture of all stigma, but I think that there's still a lot of action we can take in making that stigma less influential and less relevant in high stakes interactions.
And Elizabeth, what about over to you? What would you like to leave us with?
I think sometimes when you look at this work and that very long list on your graphs, Rachel, of how many people might have stigma attributed to them as a consequence of their disease, it can be a bit overwhelming and even a bit of a downer, right? Because you think, how can I go to how can I help? And then you look at the size of the problem. So for me, it's about taking personal action as an individual, as a leader, as a member of community. And I suppose I feel hopeful because you've had, more than 100 people here today. There are hundreds more registered who will watch this tonight while drinking a glass of red or whatever it is that they do. And everyone on this call, I'm sure, is already engaged in doing work. So I always take heart from the goodness that exists in communities and our capacity to make a change. The more we talk about these things, the more that we can make a change. And for me, it's always just one thing. So, what I'd encourage everyone to do is think, what is the one thing I could do this week? Just even a small thing, like smiling at someone that I walk past that looks like perhaps they're not having the best day, to help slowly start to turn this tide and reduce the impact of stigma in healthcare and indeed in people's everyday lives.
Thank you very much. And just to finish, we've got a plug, of course, which is for our own Stigma conference coming up in November. Abstracts and scholarship applications close August 14. Is that right, Eleanor? August something?
August 14th.
August 14th.
That's right. Sorry, I couldn't unmute myself there.
Yeah. So again, we say a big thanks to Rachel and to Elizabeth and to everyone who's contributed in the chat. This is what it's all about. We're all learning and trying to progress our own understanding. So thanks everyone for contributing, and especially to Rachel and Elizabeth for leading us off on this discussion. So thanks everyone. Have a wonderful day or evening, and we'll see you next time.